Hello everyone. I'm Dr. Arpit, your pharmacology faculty at Manipal Medes. So in this session, we are going to discuss the pharmacology session asked in the recent NEET PG August 2024. All the questions were asked from our Manipal video and the MCQs. So I'm sure if you have seen our videos and attempted our MCQs, you must be able to solve most of these MCQs correctly. So let's start with our discussion of the pharmacology MCQ based on students' recall. First question. It was a simple question discussed as such in my video lectures. It was an image-based question from general pharmacology. It depicted this particular graph and it asked the following image shows which kind of inhibition: competitive, non-competitive, allosteric or suicidal. So the correct answer is competitive inhibition. And how did we solve this? So I had told you that Vmax remains same after adding antagonist. Vmax remains same in competitive antagonism. So therefore 1 by Vmax will also remain same. So without inhibitor or antagonist and with inhibitor, the same point on 1 by V axis will be crossed. So as you can see, 1 by V is same in this particular graph. That means Vmax and 1 by Vmax are same. So this is an example of the competitive inhibition. How would the non-competitive inhibition look like on this particular graph? So in that case, we have discussed that in non-competitive, it is the Km or the substrate concentration which remains same. So then in that case, S or substrate concentration, and therefore 1 by S would remain same. So the line would cross here on the x-axis in cases of non-competitive inhibition. So we discussed exactly the same graph. It is a double reciprocal curve, and I hope you were able to attempt this question correctly. Moving to the next question. Again, a simple concept-based question from general pharmacology. It says lidocaine is given by loading dose for arrhythmia. Loading dose depends on. It's a very simple and a regularly asked question from general pharmacology. We know that loading dose is given by the plasma concentration at 0 hour. So there is plasma concentration multiplied only by volume of distribution. This is the simple formula. If we want to know the correct or the most appropriate formula, then we divide it by F or the bioavailability. So loading dose depends on the plasma concentration, volume of distribution and the bioavailability. Normally in questions, the answer that they are seeking is that loading dose depends only on volume of distribution. So option A was the correct answer. Similarly, the other dose, maintenance dose, again maintenance dose depends on the plasma concentration multiplied only by clearance, and again you can divide it by bioavailability or F. So generally what is asked in maintenance dose, that maintenance dose depends only on clearance. So very simple question, and I hope you were able to solve this very easily. The next question. Drug dose is determined in which phase of clinical trials? Now see, this question is a bit tricky. Now in phase 1, what we determine is called maximum tolerated dose. See, phase 1 we know is conducted to assess the safety of the molecule, and by safety we mean maximum tolerated dose. It is that dose beyond which we will not test the dose of the investigational drug. But that's not what is asked in this particular question. They're asking drug dose is determined. It appears that they're asking which dose that will eventually be used in patient is determined in which phase of the trial. So in phase 2, what happens in phase 2? We test 2 to 3 different doses of the drugs in different subgroups of patient, and out of these 2 to 3 different dosage, the dose that shows the best result, that dose is selected, and that dose is then confirmed in larger patient in phase 3. So dose ranging studies are conducted in phase 2. Out of the multiple dose that we test, we select the best dose to be tested and confirmed further in phase 3. So the best answer will be phase 2 clinical trial. Remember, they're not asking about the maximum tolerated dose. That dose is an upper limit. That dose is not tested further in any clinical trial, and that is not what is asked in the question. So the best answer will be phase 2, wherein we find out the best dose to be tested further in phase 3 clinical trial. So answer will be phase 2 or option B. So I hope you have understood what is asked in the question and what should be the most likely answer. Moving ahead. Now this question has not been recalled properly. The options that I have gathered from all students are bit differing from each other. The question is saying drug to be used in urinary incontinence with dementia. Whether dementia was there or Alzheimer's disease was there, or was it not at all there? There is a difference of opinion among many students who have recalled this question. Similarly, there is difference of opinion among the option. However, what we want to actually know in this particular question, see, for urinary incontinence, we want to give anticholinergic drugs. That we know that anticholinergic drugs such as oxybutynin, such as trospium, flavixoate, tolterodine, fesoterodine, solifensin. All these are anticholinergics which can be used in a patient of urinary incontinence or urge incontinence. They all will relax the bladder. So tolterodine, trospium, both are given in the option. But the question is also mentioning dementia with suggestive of Alzheimer's disease. Now for treatment of Alzheimer's disease, we want to increase acetylcholine in CNS, and that is why we give the central anti-2 cholinesterase. So we want to use such an anticholinergic for urinary incontinence in this patient that will not cross blood-brain barrier and will not oppose acetylcholine action in CNS. So if trospium was given in the option, if it was given, that will be the best answer. And however, if trospium was not given and the only anticholinergic given was tolterodine, then that would have been the answer. As I said, there is a difference of opinion among the student in this recall. So based on whatever was given, you would have marked the answer. The concept is, if the question was only asking urinary continence, then any of these anticholinergics, if given, would have been the answer. But if dementia was also given, then we are going to use trospium, because trospium does not cross blood-brain barrier and therefore will not oppose action of acetylcholine in the CNS and will not worsen the dementia of Alzheimer's disease. So that's the concept, and I'm sure you would have marked the correct answer. Moving to the next question, it is a simple, many times asked repeat question discussed as such in my videos. It says atropine is given with diphenoxylate to treat secretory diarrhea. Why? So we all know diphenoxylate is an opioid used as an anti-motility agent in diarrhea. So that is why diphenoxylate is used in diarrhea. The question is, why is atropine added? So atropine is added to prevent the abuse of diphenoxylate. So diphenoxylate is an opioid and it has some ability to cross blood-brain barrier. So diphenoxylate can cross blood-brain barrier and produce the euphoria or the pleasure that is produced by the opioid drugs. So what we do, we mix or we add atropine to the diphenoxylate in the same tablet, so that If patient tries to abuse diphenoxylate for euphoria, then atropine which is added will produce the anticholinergic side effect, and therefore patient will not be able to abuse this drug. So to prevent the abuse, we add atropine. Okay, that is the best answer. You also might recall that there is another opioid used as anti-motility agent, that is called loperamide. Loperamide does not require addition of atropine. The reason is loperamide does not cross blood-brain barrier, and loperamide itself has got the anticholinergic activity. So diphenoxylate requires atropine and loperamide does not. Both are anti-motility opioid used in diarrhea. So nowadays obviously loperamide is the one which is more commonly used. Next question. It's a very important yet simple. If you have seen my videos, patient with hypertension and calcium renal stone, best diuretic. So we know that between thiazides and furosemide, first thing is thiazides are preferred for hypertension treatment. So patient is hypertensive, so we are tilted towards thiazide as the answer. Furosemides are not the best diuretic for treating hypertension. Also we know that thiazides increase calcium reabsorption from urine. Reabsorption of calcium is increased by thiazides, and that helps in dissolving the calcium renal stones. So thiazides increase urinary calcium reabsorption, and therefore the calcium stones in urine can be dissolved. So thiazides will help in treating both the problems, hypertension as well as calcium renal stones. So that would be the answer to this particular question. Okay, furosemides have an opposite effect. You might recall, furosemides actually increase the calcium loss in urine. So furosemide will not be suited for this particular patient. So it is the thiazide which should be used in a patient with hypertension and nephrocalcinosis, particularly the calcium renal stones. Next question. Drugs or beta blockers which reduces mortality in CHF patient. So beta blockers are one of the most important drug that reduce mortality. Which beta blockers are used? There are 4 beta blockers. Earlier there were 3. Now in the latest book another one has been added. How we can remember them? You can remember best NMC. Best NMC. So that is the mnemonic to remember all the beta blockers that reduce mortality. The maximum reduction in mortality in CHF is shown by carvedilol. Then there is metoprolol. Then there is bisoprolol. And the latest addition as per the latest books is nebivolol. So these are the 4 beta blockers which have shown reduction in mortality in CHF patients. So answer out of these given will be bisoprolol. I also hope that you are also able to remember what are the other drugs that reduce mortality, which are remembered by the mnemonic best agents inhibit mortality. So this mnemonic summarizes all the drugs which reduce mortality in CHF. We have beta blockers with B. With B, we also have a combination of hydralazine with nitrates known as Bidil. Agents are all the drugs which inhibit the RAS system, that is the ACE inhibitor, ARB, and the ARNI, which is a combination of sacubitril valsartan. Inhibit are the drugs that inhibit the SGLT2, all the gliflozins, and M is the mineralocorticoid receptor antagonist or the spironolactone. So these are all the drugs that reduce mortality in CHF, and answer to this particular question is bisoprolol. How to remember? Best NMC. Next question, what is the mechanism of action of caffeine? Caffeine, we all know, has mechanism similar to theophylline. They both belong to the same class of drugs, that is methylxanthine. And what is the mechanism of theophylline? Theophylline mechanisms are pretty simple. It is a non-specific inhibitor of phosphodiesterase enzyme. So it's a non-specific phosphodiesterase inhibitor. The option said phosphodiesterase stimulation, so this is wrong. And another mechanism of theophylline is adenosine receptor blocker or adenosine antagonism, which is given as option number A. So adenosine receptor antagonism is the answer of this particular question. Whether it is theophylline or caffeine, both belong to the same class, that is methylxanthine, with the same mechanisms. The next question was from respiratory. It says, which of the following is incorrect about cyclosinide? So we all know cyclosinide has been asked previously. It is a soft steroid. The reason it was called soft steroid because it has very minimal or least systemic side effect. Systemic side effects are very, very minimal. In fact, the lowest among all inhaled corticosteroids. So let's look at the options. Oral candidiasis is more common. As I'm saying, it has least side effects. So this option is false or incorrect. Fewer side effects than other ICS. This is a correct. It has one of the least side effects even among inhaled corticosteroid. That's why it's called the soft steroid. Prodrug activated in lung. Now this is a new point. So cyclosinide is activated by esterase enzyme in lung. So there are esterase enzyme in lung which activate cyclosinide. So this point is also correct, and efficacy is similar to other inhaled corticosteroid. That is correct. All ICS have similar efficacy. So which is incorrect? Option number A is the incorrect of the four options. So that's the answer. Remember, cyclosinide, the inhaled soft corticosteroids, having one of the minimal or the least side effect among all inhaled corticosteroids. Next question was a clinical question. Patient with hypertension was on a medication with side effect of dry mouth. So patient was taking an antihypertensive drug which caused dry mouth, but he forgets to take it on a vacation and goes into hypertensive emergency. Which medication was this patient taking? So again, a question that was discussed as such in our videos on the adrenergic drugs. We discussed that clonidine, number one, should not be given to frequent travelers. That was the point that I had very, very emphatically mentioned, that you do not give clonidine to the travelers. Why? Because they may frequently forget to take the drug, and clonidine produces side effects of dry mouth, which is its most common side effect given. Along with that, it produces sedation, which has not been given in this question. But if you stop it suddenly, like the traveler who forgets to take it during vacation, it causes rebound hypertension. So rebound increase in BP is seen. So dry mouth and rebound hypertension are 2 points mentioned in this particular question. Clonidine is used as a centrally acting antihypertensive. So all the points match, and therefore clonidine is the answer to this particular question, discussed as it is in my lectures and in notes. So I don't think you would have any problem solving this question. Next, agents used for reversal of muscle relaxant using vecuronium. Again, the question that has been given as such in our MCQs. So we know that the non-depolarizing muscle relaxant like rocuronium and vecuronium. See, these are non-depolarizing muscle relaxant. Conventionally or historically, to reverse the effect of any non-depolarizing muscle relaxant, we have used neostigmine. So neostigmine can reverse their action as well. But neostigmine is a pretty non-specific drug and has some side effect of its own. So for these two, only these two, rocuronium and vecuronium, a specific reversal agent by the name Sugama Dex was developed, and this question has been asked couple of times. So sugammadex is a specific reversal agent only for rocuronium and vecuronium. Instead of rocuronium, in the question vecuronium was asked, but it does not make any difference. Sugammadex is a very, very important, and in several questions in our MCQs, both in the main Q bank as well as in the crash course, this point has been discussed. So again, no confusion, succinylcholine action cannot be reversed, and glycopyrrolate plus neostigmine combination does not make any sense. Selective norepinephrine reuptake inhibitor used in ADHD. Now again, this question has caused a bit of confusion. Some of the students say that one drug, atomoxetine, was given in the option. So if atomoxetine was given in the option, then that would be the best answer, because this drug is a selective norepinephrine reuptake inhibitor and predominantly used for ADHD. If atomoxetine was not given, as some other students are saying, then we have methylphenidate, reboxetine, amphetamine and modafinil. Out of these, it is the reboxetine which is a norepinephrine or NA reuptake inhibitor, number 1 point. It is mainly a drug used for depression, but off-label the drug has been used for ADHD. So if atomoxetine was not given, then reboxetine is the best answer out of the given, because amphetamines are non-specific drug, modafinil is used mainly in narcolepsy, and methylphenidate is again mainly used in ADHD, but again it's a non-specific and not exactly a reuptake inhibitor. So out of the given, reboxetine would be the best answer, but please remember it is actually atomoxetine, which is a selective NA reuptake inhibitor and predominantly used for ADHD. Next question, again there is not consistency among many students who have recalled this question. Some students say that it was actually treatment of sertraline toxicity, sertraline being an SSRI, that question was asked, and some other students say no, actually it was a combination of SSRI with MAO inhibitors. But anyhow, both the combinations, whether SSRI alone or SSRI with MAO inhibitors, are going to lead to excessive increase in serotonin action, leading to what we call as the serotonin syndrome, which is characterized by hyperthermia, autonomic disturbances, particularly fluctuations of BP and diarrhea, rigidity, muscle rigidity, and sometimes there is also myoclonus. So HARM, these are the predominant symptoms of serotonin syndrome caused by excess of serotonin action, whether by SSRIs alone or by a combination of serotonergic drug like SSRI plus MAO inhibitor. And the treatment of serotonin syndrome is very simple, anti-serotonergic drug, that is cyproheptadine. That is the only drug that we used. So cyproheptadine would have been the answer. If we look at other options, carnitine is mainly used to treat valproate toxicity. This question was asked in INICT a couple of years ago. Cysteine and acetylcysteine, if that is the meaning, then it is a antidote of paracetamol poisoning. Okay, so I hope in this format you would be able to solve this question. Again, a question which is a direct from my notes and videos: drug for maintenance or substitution for opioid dependence. So you know, we use what we call as the opioid substitution therapy, OST, for treating opioid dependence. There are two ways or two things that can substitute the morphine or heroin that patient was taking. The preferred, we know, is called methadone maintenance therapy. So methadone is the preferred drug, and if methadone is not available, then we have buprenorphine maintenance therapy. So either MMT, methadone maintenance therapy, or the buprenorphine maintenance therapy. Either of these can be used, with methadone maintenance therapy being the preferred option as per the WHO and all the standard books. So we substitute the morphine or the heroin that patient was taking with either methadone or buprenorphine. So out of the options given, methadone is not given, so buprenorphine is the best answer. Naloxone, we all know, is the drug of choice for toxicity, heroin or morphine toxicity. Then we give the injectable naloxone as the drug of choice, and naltrexone is taken. Naltrexone may have caused some confusion here, but please understand, once we have successfully de-addicted, once we have used methadone or buprenorphine therapy for successful de-addiction, so patient has been successfully de-addicted. Now there is a risk that this patient may relapse. So once de-addiction has been done, it is complete, patient has stopped taking heroin or morphine, then we put the patient on oral naltrexone, and that is done to prevent relapse. So naltrexone orally is given to prevent relapse after successful de-addiction in opioid. So that is not the maintenance or substitution option for opioid dependence, so that will not be the answer here. So the correct answer out of the given option will be buprenorphine, but the best answer would have been methadone if it was given in the option, but currently that's not the situation, so option number A is the correct answer. Moving to the next question, a standard question which has been asked so many times that I think no student should mark it wrong. Drug for alcohol withdrawal seizure, some students say it was to treat alcohol withdrawal seizures, some say it was to prevent, but anyhow we know benzodiazepines and particularly the shorter acting one, lorazepam, are the drugs for alcohol withdrawal seizure. The question has been asked many times, so I don't think there should be any confusion on this particular question. Lorazepam or the benzodiazepines. Next question, malignant hyperthermia, feature of which agent? Halothane, etomidate, propofol, and 2 out of the given. Halothane is the one which shows the features of malignant hyperthermia, which is due to abnormality in the ryanodine receptor, mutations in the ryanodine receptor causing excessive release of calcium from sarcoplasmic reticulum, leading to muscle rigidity. That is malignant hyperthermia. The most likely cause is either halothane or the muscle relaxant succinylcholine. These are the two most commonly drugs which cause malignant hyperthermia, and the treatment obviously is dantrolene, muscle relaxant dantrolene, directly acting muscle relaxant dantrolene. So these are the questions which are asked on malignant hyperthermia, and halothane is the correct answer here. This question has been repeated quite often. It has been discussed as such in our lectures, notes, as well as in the MCQs. So we have a boy with history of suicide attempt. He presented with intake of some drug and dilated pupil, tachycardia, hypertension. Which is the drug? So now we see morphine. Morphine causes miotic pupil, so that is not the answer here. Chlorpheniramine poisoning is not common, neither it is discussed nor that is attempted. We are left with heroin and cocaine. Heroin again is a morphine derivative, so again it will present with miotic pupil, so that also goes away. We are left with cocaine. Cocaine we all have discussed. It's a drug which increases the sympathetic nervous system activity. It's an indirectly acting adrenergic drug. So in excess of cocaine, we are likely to see hypertension and mydriasis. Mydriasis, both are given. Plus, generally, if there is history of cocaine abuse, then patients will have tactile hallucinations leading to scratch marks. So generally that is also given, but since there is no history of abuse here, there is history of suicide attempt, so scratch marks may not be present. But mydriatic pupil along with hypertension, tachycardia suggests it was a case of cocaine overdose. Patients with alleged intake of some drug and dilated pupil, again we have dilated pupil. but along with dry mouth and decreased bowel movement. What is the drug? Again, a question which has been repeated many times. So if we have dilated pupil or the mydriatic pupil along with dryness, other symptoms like delirium, decreased bowel movement, they are all suggestive of an anticholinergic profile. So drug which is anticholinergic, blocking the muscarinic action, can produce all these action. So morphine is an opioid. Chlorpheniramine does have some anticholinergic properties, so we will keep it as a possible, but predominantly the drug is antihistaminic, so we're not thinking that it is the best answer. Alcohol does not produce these kind of symptoms. Datura produces symptoms similar to atropine, and that is the correct answer. Datura poisoning or atropine poisoning or belladonna poisoning is a classical case of anticholinergic symptom presenting with the delirium, dryness, decreased movement, hyperthermia. So that is the answer to this. And drug of choice, I hope everybody recalls, will be physostigmine. Physostigmine, very commonly asked question. Another question on poisoning. So one thing is clear, that all drug poisoning are a very, very important topic for all the NEET PG exam going forward. So we have in this question, patient presented with the tachycardia, hypertension, hypocalcemia. Now hypocalcemia is something which is not commonly seen in many drug poisoning. High anion gap acidosis. Which drug is responsible? So out of the options, it is the ethylene glycol. Ethylene glycol, which is used as antifreeze in most cold countries, can cause oxalate production, and oxalate can bind with calcium, leading to hypocalcemia. Obviously, it is a type of alcohol, so it will lead to high anion gap acidosis. So that narrows down the options, and therefore ethylene glycol poisoning. I hope you remember that for treatment of ethylene glycol poisoning, like with methanol or methyl alcohol poisoning, it is the fomepizole, which is an inhibitor of the alcohol dehydrogenase. That is the drug of choice for ethylene glycol poisoning. Okay, so that is the answer to this question. Moving to the next question, we have a male who presented with urethral discharge. Staining of the urethral discharge, intracellular diplococci, treatment of choice. So urethral discharge, diplococci, the answer is gonorrhea. So we are looking at a case of gonorrhea. Now gonorrhea treatment has been asked many times recently. So that has always been an important topic in the last couple of years. So for gonorrhea, see earlier in 2 or 3 years prior, we used to give a combination of ceftriaxone plus azithromycin. That was the treatment couple of years ago, but now it has been asked previously, I think last year only, that azithromycin is no longer recommended for the treatment of gonorrhea. We can simply give ceftriaxone, and if we suspect that the patient also has chlamydia, then we can add doxycycline, but there is no indication of chlamydia, so it is the ceftriaxone which would be the drug of choice here. The options did not, however, include ceftriaxone, but we find cefixime. Cefixime is just a third generation cephalosporin, similar to ceftriaxone, similar spectrum, similar activity, and it is oral, so more suitable for the outpatient treatment. So if ceftriaxone is not given as the option, then we can definitely go with cefixime as the best option. Already I have told azithromycin, gonorrhea has developed resistance, increased resistance, so azithro is no longer recommended, and doxycycline would have been added if a suspicion of co-chlamydial infection was given. So that narrows down our answers to cefixime. HIV patient receiving treatment with zidovudine, lamivudine and nevirapine. Which of the TB agents should be avoided? This is a pretty standard question. It is the rifampicin, which can cause the induction of the cytochrome and lead to increased metabolism of the NNRTI and the protease inhibitor. So we would like to replace rifampicin with rifabutin, which has a similar mechanism of action like rifampicin but does not induce the liver enzyme. So rifampicin is the one that should be avoided in HIV patient receiving the antiretroviral therapy. So this is a pretty standard question which I am sure you would have found easy to answer. Then we came to a pretty, I would not say very difficult, but a tricky question. This question asks treatment of combined Vivex and falciparum and what is given on day 2. So first thing is, if we have a combined infection of Vivex and falciparum, then it is to be treated like chloroquine resistant falciparum. So any options that included chloroquine can be excluded. Chloroquine will not act on falciparum. The options that we have did not include chloroquine. So what we are going to give? So how do we treat? We give artesunate combination therapy plus primaquine. Now if it was only falciparum, please understand this is the trick. If it is only falciparum, then we give primaquine single dose on day 2. Focus on primaquine. If it is only falciparum, no Vivex, then only one dose of primaquine is given, and that is given on second day. And how much is that primaquine single dose? It is 0.75 milligram per kg. Clear? If it is only falciparum, that only one dose of primaquine is needed on day 2, and that is 0.75 milligram per kg. However, since in the question it is both Vivex plus falciparum, so we have to give ACT, artemisinin combination therapy, plus, now since Vivex is also there, so we will have to give primaquine, I hope you understand, for all the 14 days to kill the hypnozoids of the Vivex. Now the dose is 0.25 milligram per kg on day 1, 2, 3 on till 14 days. The question is asking on day 2. Now please understand, in ACT, as part of ACT, we are going to give artesunate. Artesunate is generally given 100 milligram twice a day. 100 milligram twice a day. So 50 milligram 4 tablets. 50 milligram 4 tablets, that is 100 milligram 2D. So that is okay. Sulfadoxine pyrimethamine is given on day 1. So SP is given on day 1. So that rules out this first option, because sulfadoxine pyrimethamine is given on day 1. Now the confusion is between option number B and option number C. Since it is combined Vivex and falciparum, you are going to give 0.25 milligram per kg for all the 14 days. So how much will you give? If you calculate for a 50 kg, it will be what? 15 milligram approximately for 50 to 60 kg, 15 milligram. So 2.5 milligram, 6 tablet, that is 15 milligram per day for an average patient of 60 kg. So that is the answer. Option number C is the answer. Had it been only falciparum, that is the trick here. Had it been only falciparum, then please remember, day 2 0.75 milligram, because we are giving only one dose as gametocidal, then this would have been the answer. So this is a very tricky question, not a difficult but a tricky, and the presence of mind has to be shown that since it is a case of combined infection, so therefore primaquine will be given on all 14 days, and then the dose is 0.25 milligram per kg. So we have to give 15 milligram per day, that is 2.5 milligram 6 tablet. Had it been falciparum, then it would have been the larger primaquine tablet, 7.5 milligram into 6 tablet. So I hope this is clear why this question is tricky, and whenever such question come, you have to rely not just on the knowledge of pharmacology but also what is taught in the national program in the PSM. So this is an integrated classical example of an integrated question between pharmacology and PSM. So I hope you have understood and will be able to attempt all such questions in future. Moving to the next question. Antithyroid drug in first trimester. So we all know the preferred antithyroid drug in pregnancy is propylthiouracil overall. If you are asked trimester wise, then in the first trimester again it is propylthiouracil which is preferred. But if it is second or third trimester which is asked, then we shift to carbimazole or methimazole. Okay, I hope you know why propylthiouracil, because it is safer in pregnancy. It's safer in pregnancy. Carbimazole and methimazole produce teratogenic, the classical example of their teratogenicity being cutis aplasia. They cause loss or non-formation of skin at some of the places, aplasia cutis or cutis aplasia along with corneal atrosia. So these drugs are not considered safe in pregnancy, and that is why answer will be PTU. Then you might ask, sir, why in second and third trimester we are referring back to carbimazole? Because organogenesis is over in first trimester, so risk of teratogenicity decreases, and PTU is highly hepatotoxic drug, so we want to prevent hepatotoxicity or reduce the incidences of hepatotoxicity in mother. So once organogenesis or the first trimester is over, then we shift back to carbimazole or methimazole for the remaining trimester. So since it is asking about first trimester, PTU or propylthiouracil is the best answer. This is the new question. HIV lipodystrophy patient, which growth hormone analog can be used? So there are several HIV drugs like the protease inhibitor, like the NRTI, which can cause lipodystrophy. Lipodystrophy is a mix of lipohypertrophy and lipoatrophy. So at some places patient develops excess of fat like at back of the neck, and other places like in the face there is atrophy. Which growth hormone analog can be used? It is tesamorelin. This is a specific growth hormone analog which is used specifically to treat the HIV associated lipodystrophy. Remember, growth hormone reduces adipose tissue, so that is why we are using this. Mecasermin is a recombinant insulin-like growth factors which is used in Lorentz syndrome, and octreotide you all know is a somatostatin analog used for multiple indications. We had an image-based question. Something like this image was shown, that plasminogen to plasmin. This conversion is blocked by which drug? So I hope you can recollect from our discussions in our lectures, plasminogen to plasmin. This conversion is done by plasminogen activators like streptokinase or the tissue plasminogen activator or the alteplase. So they are called fibrinolytic agent. These drugs are fibrinolytic. So which drug is going to inhibit this? That will be antifibrinolytic. So we are going to find any antifibrinolytic drugs from the given option. We know that there are only two antifibrinolytic, epsilon aminocaproic acid and tranexamic acid. Two drugs are there. Out of this, EACA or epsilon aminocaproic acid was given, so that would have been the answer. Okay, some of the students in hurry did not read the question carefully and wrongly marked streptokinase, but streptokinase, please remember, would have been this plasminogen activator, not the inhibitor. Okay, so EACA or epsilon aminocaproic acid or tranexamic acid, which are used as antidote to streptokinase, reduce or stop bleeding caused by the fibrinolytic overdose. The next question, Pregnant lady. Now, what week of gestation was given? Again, there is some confusion. Some are saying 30, or some other students are recalling as 36. But anyhow, we have a pregnant lady at these weeks of gestation. She is on warfarin. What should be the next line of management? So you see, low molecular weight heparin are the preferred drug of anticoagulation in pregnancy, that we know. That overall it is the low molecular weight heparin which should be preferred as the anticoagulant in pregnancy, because warfarin is simply teratogenic, causes chondrodysplasia. If we look at trimester wise or week wise, then 1 to 12 weeks we use only low molecular weight. We do not use warfarin. From 12 to 36 we can again continue to use low molecular weight, but we can if needed, if the patient is unwilling to take injection, we can use warfarin. And at the near term or near 37th weeks onwards, again we have to shift back to low molecular weight heparin, again warfarin, because warfarin action would take time to stop or time to reverse even if we stop it, leading to the risk of neonatal hemorrhage. So this is how we use, or the guidelines suggest use of anticoagulation. Now, out of anything, the preferred is low molecular weight heparin in any trimester, any week in pregnancy. So whenever you get such a question, if the option says switch to heparin, it is the best answer. It is the best answer. It does not matter if the patient was at 30 week or 36. If the question is asking what should be done, switch to low molecular weight heparin, because that is having the safest anticoagulation profile in pregnancy. Next question came from hypolipidemic drugs. A patient taking drug for dyslipidemia developed flushing, hyperglycemia. Identify the drug. Very simple. This is nothing but our favorite niacin or nicotinamide. Now you all know niacin can increase the prostaglandin synthesis, and prostaglandin synthesis can cause pruritus or itching and flushing or warmth. Along with that, niacin has several other side effects like hyperglycemia, hyperuricemia. So obviously niacin side effects have been asked very, very commonly, and therefore niacin is the correct answer here. Statins mainly cause myopathy and hepatitis. Fibrates can also cause mild hepatitis or mild myopathy, and one of the fibrate, that is clofibrate, can cause some gallstones also. But it is the niacin whose side effects have been asked many times, and again we have got the question. The only other question which can be asked in subsequent examination, that which drug we will give for treatment of niacin induced flushing and pruritus. So conventionally we add aspirin to niacin, but recently there is a prostaglandin receptor blocker by the name laropiprant that is also available in combination with niacin to prevent these prostaglandin induced pruritus and flushing. So next time maybe aspirin or laropiprant can be asked. Multiple myeloma drug that can cause herpes zoster reactivation. So again, sometimes students just read reactivation, and some of the students have thought of the TNF alpha inhibitors that cause TB reactivation, but that was not the case here. So this is a specific question on bortezomib. Bortezomib, which is a proteasome inhibitor. Carfilzomib, bortezomib, one of the first line drug for treatment of multiple myeloma, and they can cause reactivation of herpes zoster infection. So that maximum reactivation of herpes zoster has been seen with bortezomib or corticosteroids, which are both used. But again, a study has shown that bortezomib has the maximum incidences of the herpes virus reactivation. So that will be the answer. Lenalidomide, thalidomide can also cause immunosuppression, but they mainly cause reactivation of cytomegalo. And daratumumab, it's a new drug, It's a new drug again for multiple myeloma against CD38. CD38 inhibitor daratumumab, but the best answer here will be bortezomib, which can cause reactivation of herpes. Moving to the next question. Methotrexate reduces the synthesis of. Now what is methotrexate? So we have the dihydrofolic acid, which needs to be converted into tetrahydrofolic acid. The enzyme is DHFR. Once the tetrahydrofolate or FH4 is formed, it is essential for synthesis of the tetrahydrofolate is essential for conversion of the deoxyuridine monophosphate to deoxythymidine monophosphate, where the actually enzyme is thymidylate synthase. This is the process. Where does methotrexate fit? We all know methotrexate is inhibitor of DHFR enzyme. That is what methotrexate does. So once we give methotrexate, this dihydrofolate reductase enzyme is inhibited. So FH4 is not formed, and if FH4 or the tetrahydrofolate is not available, then thymidine synthesis cannot occur. So methotrexate reduces the synthesis of. When this question is asked, without any shadow of doubt, the answer is TMP, thymidine monophosphate. Thymidine cannot be formed because the tetrahydrofolate availability will reduce. So that's the answer to this particular question. Which of the following is mechanism of action of aprepitant? So again, simple question directly from the notes. So we have chemotherapy induced nausea and vomiting. Chemotherapy induced nausea and vomiting caused by highly emetogenic drugs like cisplatin. So for treatment of chemotherapy induced nausea and vomiting, we know that the best drugs are drugs like ondansetron, granisetron, pelonosetron, which are 5-HT3 antagonist. So it is the cetrons which are 5-HT3 antagonist. So you can rule out that option. If CINV alone is not controlled by ondansetron, then frequently we add a steroid by the name dexamethasone. So dexamethasone is frequently added to provide the anti-inflammatory effect, and still if the patient continues to vomit, then we add a new class of drugs, that is what is aprepitant. Aprepitant, netopitant, rolapitant, all are blockers of substance P receptor, and which receptor? Neurokinin 1 receptor blocker. And that is the answer to this particular question. Aprepitant, netopitant, rolapitant, all these pitant drugs are blockers or antagonists of substance P receptor. And which receptor of substance P? Neurokinin 1 receptor. So that's the answer to this particular question. What is not monitored during magnesium sulfate therapy? What is not monitored during magnesium sulfate therapy for eclampsia? So magnesium sulfate drug for emergency blocks calcium entry, causes relaxation of smooth muscles, whether used in eclampsia, whether used in bronchial asthma sometimes. So the toxicity is indicated by loss of deep tendon reflex, so that will be monitored. Magnesium sulfate can cause diuresis, and if the urine output decreases, then even magnesium clearance can be affected. So you will have to maintain a chart of the urine output. So that will be. Magnesium sulfate can cause respiratory depression, it can cause cardiac arrest. So respiratory rate, BP, all these parameters will be normally monitored. Serum magnesium levels is something which is not usually monitored. Only when there is suspicion of confirmed suspicion or high grade suspicion of magnesium toxicity, then we take serum magnesium levels. So out of the given option, this will be the best answer, which is not routinely monitored. Okay. So that is all. We had approximately 30 questions, and of these 26 to 27 have come from directly either from the lectures or from the MCQs that I have developed for the Manipal Medace. So overall, I would say it was a good paper from pharmacology. The questions were from across various topics in pharmacology. We had a good coverage of not just the topics but also the severity. Some of the questions were simple, some were clinical based, and some obviously, like the bortezomib one, were based on new findings or new drugs. The questions had a good mix of direct questions like mechanism of action, like some of the side effects, as well as some of the integrated questions like I told you about falciparum, which had a good integration of PSM with pharmacology. If you had studied from Manipal days, looked at my lectures, I am sure that you would be in a comfortable position in these papers. It is not just pharmacology, but across all the subjects that Manipal Days has a strike rate of about 95% questions coming directly from the lectures, notes, and the MCQs. So you all know, but I will still repeat that at Manipal Days, we are constantly trying to improve our already good content curated by the faculties themselves to provide you the best available content in the shortest possible time. So there is no overload of the content. Content is crisp and comprehensive at the same time. The questions are as real as they come in the real NEET PG or the INI-CT exam. So with that, I would say thanks to all of you for being very patient listeners. If you like this session, please subscribe to the Manipal Days and keep following us for many such good, informative, interactive sessions. Thank you.